Welcome to everybody officially to the 6th session of the International Deprescribing Journal Club, hosted by the Canadian Medication Appropriateness and Deprescribing Network, also known as CADeN. A reminder that this International Deprescribing Journal Club is the product of a collaboration between the Australian Deprescribing Network, the US Deprescribing Research Network, the Network of European Researchers in Deprescribing, the European Society of Clinical Pharmacy, and CADeN. We do want to thank all of these groups for their efforts in collaborating with us to plan the different sessions that have been being held. Oops. So I am the moderator today. My name is Jim Silvius. As a short introduction, I'm a geriatrician in Calgary, Alberta. I'm also a senior medical director with Alberta Health Services, and my role with CADeN is as executive director. I have no interests to declare, no conflicts of interest to declare. I definitely have interests. We wanted to provide a brief land acknowledgement, which is traditional in Canada now. And so I'm going to read it out. We honor the many traditional territories upon which the directorship, staff, members and partners of the Canadian Medication Appropriateness and Deprescribing Network live and work. And my apologies, I think I have the wrong version. Give me 1 second. Sorry about this. I just want to make sure I've got the right one. Okay. So we honor the many traditional territories upon which the co-directors, Dr. Emily McDonald and myself, the staff, members, and partners of the Canadian Medication Appropriateness and Deprescribing Network live and work. We acknowledge that our offices located in Calgary, where I am speaking to you from today, and Montreal have long histories as the home and gathering place for many Indigenous peoples. In Calgary, it is the Blackfoot as well as the people of the Treaty 7 region in southern Alberta and of Métis Nation of Alberta Region 3 who are deeply connected to the land and continue to make their home here today. Our Montreal office is located on the unceded territory of the Mohawk Nation. We are committed to humbly learning from and to partnering with Indigenous communities in research and actions reflecting their priorities and their ways of being, knowing, and doing. I also want to acknowledge the financial contribution from Health Canada, which has made this event possible, and to be clear that the views expressed herein do not necessarily represent the views of Health Canada. Just a reminder, because not everyone is able to attend live, especially since we are living in different time zones, we will be recording these sessions. Please take note that this recording will be posted on the CADeN YouTube channel later today. This recording will be posted on deprescribingnetwork.ca journal-club, as it says. Our speakers today have kindly accepted to share their slides following the presentation. These will also be posted on CADeN's website, more specifically on the Journal Club webpage. You may also consult this webpage to view all previous Journal Club sessions. And now I would like to introduce our speakers. Farrell is a senior scientist at the Appropriateness Research Institute and CADeN executive member and co-founder, and CADeN Healthcare Provider Committee co-chair from 2015 to 2023. Lalitha Raman-Wilms is professor and dean, College of Pharmacy, University of Manitoba, and CADeN Healthcare Provider Committee co-chair and CADeN Research Committee member. And Cheryl Sadowski is a professor at the Faculty of Pharmacy and Pharmaceutical Sciences at University of Alberta. She is also a member of the CADeN Research and Healthcare Provider Committees. And I would like to invite our speakers to unmute and share their presentation, please.
Thank you, Dr. Silvius, and welcome everyone. We'd actually like to start our journal club today by first finding out where everybody's from today. Where are you joining us? So we're going to start with a brief poll, and you will see that on your screen. If you can please let us know where you're currently located. If you're in Canada, please let us know the province or territory. You have to type this in. Otherwise, please write down your country as well. We'd also be interested in knowing what role or position you hold currently. So you will see a variety of descriptors. Please, I would recommend that you check all that apply to you. If you don't see a role that reflects your current position, please do feel free to check other. And then there's a third question where you can actually fill out what your current role is. I will give a few seconds for us to fill that out, please.
So I see that most people are educator and clinician pharmacist and also researchers.
And thank you, Nin. And can you tell us about where they're from? Are you able to see that?
No, I'm not able to see.
Okay. We do understand from registration there were many Canadians, but also many international participants as well in today's session. So welcome, everyone. So with that, one of the things I would say is we're sharing screens here. And so I am just going to move forward and see if that's going to work. There we go. My apologies. I think I moved forward too quickly. And okay, so in today's session, we will talk about the interprofessional deprescribing competencies, where we'll share what we have come up with in that area. We'll also look at ways to incorporate deprescribing within health professional curricula, as well as strategies for teaching and assessing, as well as evaluating these competencies. As Dr. Silvius has mentioned, the three of us speaking today, so please bear with us as we transition speaker to speaker in terms of sharing a presentation as well. I will start off by providing a bit of an overview around the process we used in developing the competencies, some information that's included within the paper, and then Dr. Sadowski will follow me. There seems to be a little bit of a lag as I go to the next slide. There we go. I have no specific conflicts to declare related to this presentation, and you can also see the declarations from the other two speakers as well on the screen. So today we're going to be talking about the proposed curricular framework for an interprofessional approach to deprescribing. This manuscript was published in Medical Science Educator in February 2023. And I believe one of our administrators will post the link to the article in case you've not had a chance to see it in the chat. So I would encourage you to click on that as well, because we will touch on different parts of the article this morning, this morning for me, but I know we're in a variety of time zones today as we walk through this. I do want to say that there's been a lot of interest in this paper since it's published. I checked this morning in terms of Altmetrics, and there's been more than 4,000 times it's been accessed so far since February, end of February. So certainly there's been a lot of interest in this paper. And I also want to share with you as to why we went about developing this paper. We do know through surveys across Canada, as well as through focus groups and an international symposium we had back in 2018, that although deprescribing may be taught in various programs, it really is not taught consistently, and it's not always taught in terms of covering all of the competencies that are really required to effectively practice it. And if as an example here, if we were to search on the web, deprescribing education, you can get more than 200,000 results. There's quite a bit of information that is available out there around seminars, lectures, case scenarios, workshops, and so on. And yet there is inconsistency in terms of how we teach it currently. So this was really the impetus for our group, the Healthcare Provider Committee of the CADeN Network, to really develop these competencies. So what was the starting points? How did we go about doing this? This was a long process. I will share that with you. It took us about 3 years to get this paper out. We started with the patient-centered 5-step deprescribing process that was published by Emily Reeve and her colleagues. That was published a while back. And then in addition to that, we also know that deprescribing is a continuum of good prescribing. So with that in mind, there are competency frameworks for prescribers that are published and really embedded within curricula as well. So we did consult also with the Royal Pharmaceutical Society's competency framework in the UK, as well as the Prescribing Safely Canada physician prescribing competencies that is put out by the Royal College in Canada. So the UK and the Canadian versions were used. And we wanted to ensure that the deprescribing competencies we developed really aligned with the prescribing competencies. And so these were some of the building blocks that were used. And then the medication, the healthcare provider committee of the Canadian Medication Appropriateness and Deprescribing Network really came together in addition to a environmental scan, a literature review. And through these process, there was really a consensus building process that we used in developing the competencies. So a couple of things I'll share with you around the background of this and how we aimed on the competencies towards. We believe that education is really important across the stream of learners, from pre-licensure students to clinicians who are practicing. And deprescribing really needs to be embedded and taught and really understood across the spectrum of learners. As well as deprescribing is relevant to really all health professionals. Having said that, we do know from a previous study we've done that physicians, pharmacists, and nurses most closely indicated that they have a clear role in the management of polypharmacy, with other health professionals, such as physiotherapists, for example, indicated an important supporting role. And so with that in mind, we really aimed our paper and the competencies to focus more on the physician, pharmacist, and nursing educators. And then in terms of the learners themselves, although across the spectrum is really important, we focus more on the pre-licensure students. So it doesn't mean that these competencies aren't applicable across the spectrum, but we really aimed at the pre-licensure students for all three professions. The other thing I will also add is deprescribing is important across the age group. This paper, as you'll notice, really does focus on the older adult. So with that, these are the 7 deprescribing competencies. And when you read them, you will see that they do align very much into the prescribing competencies as well. For example, starting with conducting a comprehensive patient medication history, this is a first common step for prescribing as well. And then really looking at the outcomes and goals of care, identifying what are potentially inappropriate medications, weighing the benefits and harms of the medication, and then making a decision if deprescribing should be carried out through a shared decision-making process with the patient or the caregiver. And finally, if we're moving ahead, then designing, documenting the plan itself, and then monitoring patient progress and provide support. So these are really the high-level competencies that are included in the paper. One of the things I do want to touch on is that just ensuring students or learners have the knowledge and skills related to the deprescribing competencies isn't enough to ensure that this can happen in practice. So you always need to be cognizant that deprescribing doesn't happen in a silo. It really should happen within a team approach. And so with that in mind, we need to ensure that we're also covering interprofessional competencies in terms of the education piece of it. And I know many programs already do that. In Canada, we have the Canadian Interprofessional Health Collaborative that has outlined the CIHC competency framework. And I can speak for some of the health professions like pharmacy, for example, where it's mandatory to cover this in terms of interprofessional education within our pre-licensure students' curricula itself. So ensuring that interprofessional competencies are covered. And then, of course, for effective deprescribing, the system also needs to support it. We know in terms of the barriers and facilitators that have been identified, not having access to health records can be a barrier. So ensuring that things are in place within the health system is really important. So integration of all of these concepts are important to effective deprescribing in practice. I want to briefly just touch on when we talk about educational interventions, there are many different frameworks that can be used around building, especially clinical skills. Miller's framework is one of those frameworks that's used commonly in all health professions, and it's applicable to health professions. And so in this framework, we really know that when we want to teach something, we really do need to start at the knowledge level and then move on to having the learner know how to apply that knowledge, being able to show how they can do it in terms of demonstrating it, and then, of course, actually doing it in practice, which is a key. And how we teach it should align with how we assess them. For example, if it is knowledge-based, a written exam can certainly assess that. Whereas if we're looking at the action-oriented or performance, using of simulated patients, or of course, in real practice in terms of experiential learning, would be a good way to assess that. So we're moving from the knowledge or cognition base to really ultimately being able to change the behavior when we talk about clinical skills related to deprescribing. And so the paper itself is really to enable healthcare educators to integrate and assess deprescribing knowledge and skills into teaching and clinical practices. and then really to provide learning outcomes within these competencies at different levels. And I will share a little bit about what I mean by different levels, as well as some teaching and assessment strategies. When we talk about different levels, when we think of a program, we have an early learner, and then we have advanced learner who's actually, for example, during experiential training, maybe applying it in practice. So when we teach it, we really need to scaffold the knowledge and skills as they build towards that. And so the way we built the paper is in the information within the competencies, we've actually looked at the knowledge and skills at the various levels and how one can actually introduce it within a program. So in the next few slides, I'm just going to walk us through briefly in terms of what is included in the paper in addition to the competencies. And again, if you've not had a chance to do so, if you do have the link to the paper that should be in the chat, please do follow that with me if you'd like. So in addition to the competencies, we have a list of knowledge and skills proposed for each competency, and this is outlined in table 1 of the paper. As an example, for competency 1, conduct a comprehensive patient medication history. And what you'll see in this is, for example, how it's aligned with the Canadian prescribing competency, as well as the Royal Pharmaceutical Society competency in the very top. So for each of the competencies, you'll see how we've aligned it with the prescribing competencies, and then the knowledge that's required to meet that competency and the respective skills for that. In addition to that, we've also included teaching and assessment strategies. And what I will say is these are not all inclusive. These are examples and that evolve with the learner level. Again, I'll share an example. This is included in table 2 of the paper. So please take a look at it. The proposed learning outcomes, we've divided into the introductory or the early learner, the mid-level learner, or the advanced learner. And so what this does is it allows each program, and depending on the profession as well, to determine for each competency, at what level should their graduates be at, and really ensure that they can actually then embed the program, within the program, the competencies and the level they need to achieve that. As an example, in the early learner, we'll likely teach them about understanding what polypharmacy and deprescribing is, being able to define potentially inappropriate medications. Whereas a mid-level learner, they really need to be able to apply the tools to identify inappropriate medications. And the advanced learner, it may mean critiquing the tools. There was only tools. So how do you actually undertake deprescribing and decision-making when the tools can't be used, for example? And then we also have some practical deprescribing resources included in table 3. And I'm just going to show that to you. Again, this is in the paper. One of the things I will suggest is, in addition to the case reports, workshop material, manuscripts we've included in here, we have also included the websites of many of the deprescribing networks. And there's a wealth of resources in these, including case scenarios you can use, patient information, seminars, and so on. So I would really encourage you to take a look at the resources as well and how you can actually utilize that to embed within curricula. And then finally, this is included more as a supplementary information and mapping exercise to help assess gaps within your own curriculum. So looking at what you're currently covering, what else do you need to cover to make sure the competencies are included within the program. And Dr. Farrell will cover this in her presentation and walk us through this. And so that gives a bit of a framework around what is actually included in the paper. We have the competencies included, as well as all of these different components around teaching and assessment strategies and the knowledge and skills specifically required under each competencies. I'm now going to call upon Dr. Sadowski to talk about deprescribing education overall.
Right, well, thank you. I'm going to be talking for a few minutes here about some of the evidence that we used related to this framework, and also just in some of my own practice as an educator as well. Now, most of you are familiar with the diagram on the left. For decades, we saw that type of diagram when we taught our students about evidence-based medicine or evidence-based practice. And there was a few considerations there. And we created a hierarchy, which you can see at the top of the iceberg, where we valued certain kinds of evidence that helped inform us. So randomized controlled trials, for instance, become something that we look to when we want to assess if something is effective or not. We look at safety within those trials. We critique that table 1 of demographics where the groups evenly matched. And so we go through this practice of critiquing these different levels. So we look at different types of studies. We synthesize the studies. But what has evolved, and this is a proposed diagram of many of the different changes in the ways we're thinking about equity, diversity, and inclusion, and how that creates the evidence that we have, and how that changes. Instead of just a pyramid, it's a bit more maybe thinking about an iceberg, that there's lots of things that are under there we're not considering. Oh, I think I might have moved ahead too quickly. So when we think about our role as clinicians, even in geriatrics, we would maybe critique, as in geriatrics, we often critique the type of evidence that's available. We are often concerned that older adults are not represented in randomized clinical trials. We still use the evidence, we still consult the evidence, and many of us as researchers are still involved in helping to create that evidence as well. But when we think about our own practices as educators, are we evidence-based teachers? Are we evidence-based educators? Are we pulling together the literature to inform us how we plan our lessons, our sessions with students, how we handle issues when we're acting as preceptors, when we think about group teaching versus assigning a self-directed activity? Sometimes for healthcare educators, in some cases, the first time that we thought about this was actually during COVID, when we thought about, is there evidence to teach online? What can be taught remotely? And there's a large body of literature, but many of us are not engaging with that due to all of the demands we have in other aspects of our work. So my experience as a faculty as an educator at a faculty of pharmacy, there's always tension because of the amount of material in our curriculum and where things are placed, how things are sequenced, if something should be didactic, if something should be in the skills lab, should it be case-based? And so we have these discussions every month, essentially, at our curriculum committee. And I had proposed doing a seminar in my geriatrics portion of teaching at the end of year 3. And I was told, well, they already know all about deprescribing by then, because they've done it in a skills lab where they learned about PPIs, or they've done it here where they had one little activity or someone mentioned it in a lecture. And so I thought, well, I need to look at the evidence. That doesn't quite make sense to me that we would not cover deprescribing as we talk about older adults. And so not only where is it in the curriculum that I'm part of, but what does the literature say? When's the best place? And so I got together some students, colleagues, and we met with our librarian and wanted to conduct a scoping review. And so we presented this at the American Geriatric Society last year. So it's in progress. And we found 46 different papers that we were able to use to tell us a little bit about deprescribing education. Sorry. In terms of the content, there's really quite a lot that's available, and it's intriguing to look at this literature. So you'll notice there's quite a few different forms of delivery. What we found as we pulled through the information out of these studies is, in most cases, the literature is not about the deprescribing education. Most researchers are presenting this in terms of, we had an intervention study and we wanted to look at reducing PPIs in long-term care. That was the intervention, to bring clinicians into that setting. And we're comparing one facility to another. But in order to get there, we had to, do some kind of education with the staff. We had to teach them something. So that's one line in the paper. And then the real intervention is them going out into the facility and practicing what they supposedly learned. But I think what researchers are sometimes forgetting is that educating people to do the study is an intervention itself. Education is an intervention. And so we tried as best we could to gather the information from these papers as to how was the education designed, how was it delivered, who was involved, who did the teaching, who were the learners. And we looked at both undergrad and practicing professionals. And we found, for example, a few gaps I'm highlighting to you here. There was only 9 studies that had a control group. So you can imagine if you were doing a meta-analysis of a medical intervention, you would find a lot of difficulty there looking at some of these designs. You can also see the outcomes are quite diverse. Only 4 had long-term follow-up. So they would essentially give an educational intervention, give a test immediately after, as soon as that session was over, and then assume that the education was really good. So we are happy to share more details of that if you'd like to follow up with me, and we're hoping that will be published within the next year. But I just want to challenge you as you're thinking about the education that you do. You actually spend a fair bit of time in your day in talking with colleagues, with patients, with other educators, with students you're precepting in the classroom, whatever setting that is. You're actually doing a lot of teaching, and you're also doing learning at the same time, but we rarely think of that as an intervention. And if we do think of it as an intervention, we rarely think of it as an intervention worth studying. In the biomedical model that we have, we highly value clinical research and studies that look at one health technology over another, but we really undervalue education as an intervention, despite so much of our time being focused on that. And so I want to challenge you to think about your role as an educator and also your role as a researcher, researching education and sharing some of what you have learned. So I leave these questions with you to think about in terms of your role going forward. All right, well, I'm going to move forward here, and I'm going to hand this next slide over to Barb Farrell.
Perfect. Thanks, Cheryl. And Cheryl's going to advance my slides as we go, but we'll stay with this one for the moment. I wanted to talk a little bit about the challenges and successes of putting this paper together and getting it published over the last several years. And I'll start, first of all, by thanking Lalitha and Cheryl, who have provided just a significant amount of leadership in getting this done. I'd also like to acknowledge all 15 author members, the group of authors who put together this paper. I have to say that's one of the first challenges, and each of these challenges is also a success because we had 15 people working on the paper, which I'm sure you can imagine is challenging to coordinate. We ended up with an extremely lengthy Google Doc where we would sometimes ask people for a paragraph on a certain thing and they would submit 4 pages. And so it became extremely lengthy. And we also found that with people coming from different perspectives, so we had physicians, nurses, pharmacists involved in writing this, that people had different ways of wording certain things or different preferences for certain types of wording. So for example, should we use therapeutic outcomes or should we use goals of care? And so in the end, we ended up using both those phrases, which sometimes makes some of the competencies look a little bit wordy. But if you're wondering why, it's because we were trying to meet the needs of all audiences. We also recognize that each profession is going to have to look at this framework and determine what is most appropriate within their profession. And that may require some small modifications to wording, et cetera, that would be appropriate to kind of adapt it more to a local context. So having said that, yes, we had a lot of authors, a lot of author input. That's why it took us 3, probably actually 4 years from the inception of the idea to actually get to a point where we had something manageable that we could submit to a journal. And along that way, we actually did stop and have some discussions about, okay, now we're at like a 15,000 word document because everyone has contributed so much content. Should we just produce a white paper, which we would publish on the Canadian Medication Appropriateness and Deprescribing Network, or should we actually try to publish this? And that led to some interesting discussion as well, because as Cheryl points out, we need to be going about this in a rigorous and an academic way. And so we did end up formatting and submitting to medical educator, which It turned out to be a great journal because of the open access option. And we thought we could reach all of the professions that we wanted to reach. We also looked at interprofessional journals, but again, we wanted to make sure that we were reaching educators as our target audience. And so we were very glad to have their support. The next step or challenge, as many people will identify with, is the concept of responding to reviewer comments. And I have to say that I was surprised actually that the reviewer comments were as succinct as they were. It seemed that people really liked the paper, the concept. They were happy with our methods, which really were via consensus versus something more rigorous like a Delphi consensus, for example, but a group consensus and a really exhaustive literature review. The main concern was whether or not this was implementable in an already crowded and busy curriculum. And because the comments were coming primarily from physician reviewers, we engaged the 4 physicians on our writing team, and they were a big help in putting together a response, as well as a template that people could use for mapping curriculum that demonstrated the links to the deprescribing competencies to prescribing competencies, which we knew to some extent were already covered in medical curricula. So I'll talk a little bit more in a second about that particular document that we created for a mapping exercise. I just want to highlight that our next challenge, and we again already have some successes in this area, is around knowledge mobilization. And Brenda Schuster has joined our team to help us in taking on the co-leadership of the knowledge mobilization strategies, as well as evaluating our knowledge mobilization efforts. And those include workshops that we've been presenting at various healthcare provider education conferences, as well as this journal club, a recent webinar for people who previously attended our workshops, and other strategies such as submitting commentaries on the curriculum paper to different publications to help with spreading the reach of the paper. So we'll go to the next slide now, and I'll just explain how to use this supplementary file. So when you are on the paper website and you scroll down to the supplementary file section, you can pull this up. It's essentially a template that will allow curriculum planners and curriculum committee members to essentially map their current approach. So we've started with the Royal College Competency on the left, the relevant deprescribing competencies, and then basically left boxes where people can indicate examples where the relevant knowledge and skills from table 1 are already taught within the curriculum, examples where those competencies are assessed, and then there's an opportunity to address whether knowledge and skills for deprescribing for that competency are taught at an appropriate level for the particular learners within that program. And that references table 2 that Lalitha spoke about earlier. And then this allows you to identify gaps or opportunities to move forward. So we'll go to the next slide now. This is just really a summary of everything that Lalitha and Cheryl have already said in terms of where we are now, that there is some deprescribing being taught out there in a variety of different formats, tend to be with by people with experience in geriatrics. Some students are engaging in deprescribing during experiential education, and there's there's spots where deprescribing is integrated into geriatrics or other courses. However, there's a big lack of consistency, and there's a lot of variability between programs. So in terms of what's needed, we've outlined here what needs to be taught, and moving back again to the paper itself, what teaching or learning strategies can be used, and what's needed next in terms of assessment, accreditation, approaches to build capacity, continuing professional development, and research in terms of evaluation of strategies to try to understand what works well and indeed what outcome measures we should be using to determine what's working well. So we'll just go to the next slide. And this particular section is drawn, copied and pasted really from the curriculum paper itself, where we have set out recommendations for all of you to, in the next year, examine what needs to happen either within your profession, your particular program, or maybe across interprofessional curricula, to actually map your curriculum using the template that we've provided, and develop a plan to move forward that identifies where you can create opportunities, where you can determine how those deprescribing competencies will be taught and addressed, how you might use the practical tools from Table 3 throughout, and ultimately to evaluate those core deprescribing competencies of graduates to determine how effective the curricular changes are. And we hope that people will share learnings and outputs. One of the next, I think, international events where there will be an opportunity to share learning is going to be at the next International Conference on Deprescribing in September in France, for example. But there will be other opportunities as well. And certainly we would like to keep in touch with people who are trying to make these changes so that we can highlight them in things like the Canadian Deprescribing Network newsletter and various other venues. So I will stop here, and I think I'm going to hand things over to Jim next, who is going to lead us through some discussion, and we're looking forward to hearing if and how people are already using content from the paper or what questions you have. Thanks.
Great. Thank you very much to all three of our speakers. Now we are moving into the discussion portion of the meeting. The questions will not remain on the screen, but they are in the chat for you. They're posted. And I would open the floor, please. Anne.
Hello, good evening. Thank you for the presentation. Very nice to have it on the publication. My question relates to the fact that you mentioned that the framework was designed in relation to deprescribing for older adults. If we want to implement an initiative at the faculty level, it is likely that we would like to expand this to other considerations, including internal medicine and younger adults. So what do you think in the current framework is not applicable if we want to expand? And what do you think would be missing? So yes, really my question is, can we use it as such if we want to have quite a more broader scope in the development that we want to make, or do we need to change anything?
Oh, Barb, you're still muted. Thanks.
I can start, and then Cheryl and Lalitha can pop in too. My thoughts are that the skills required are going to be pretty consistent across different types of groups. However, some of the knowledge may be a bit different. So for example, if you're thinking about deprescribing in children, in young people, there might be some different knowledge around medication use, metabolism, effect, et cetera, that might need to be considered, because we've focused a lot of our knowledge components on, how pharmacokinetics changes with age, for example. Those are my thoughts. Lalitha or Cheryl?
Yeah, I would also share, I agree with Barb. And what I would also, in addition to the knowledge, is some of the skills, for example, how to share decision-making happen in different age groups. That may be something to think about. So that's where you'll see the nuances. For example, knowledge, Barb mentioned knowledge. We'll see things like they need to understand geriatric syndromes. They need to understand what are common conditions in older adults. And so that's where it'll have to be tailored a bit more to the population they're working with. Ideally, it should really apply to, again, all populations, as we mentioned, but we have taken a focus on the geriatrics. But I would say the competencies overall are applicable across.
Yeah, I would agree with that we started probably with geriatrics and it's the most, I would argue in some ways, the most complex population we're seeing so much polypharmacy and so on, pharmacokinetic changes that have occurred with aging. And so it's probably easier to apply this to a younger population. There's some different special group considerations, such as, different ethics that might be considered in psychiatry or with children, and shared decision-making might be applied a little bit differently in some groups. But the bulk of the material is going to apply. So I think there's very little adaptation you could, and even at my own institution, we are using this across our curriculum, and we are including cases and examples where we talk about deprescribing across the lifespan. So.
Thanks, Mike.
Great. Thanks, Jim. Great presentation and really important work. You may have already mentioned this and I missed it, but I'm curious to how you think about sort of translating the competencies and skills that people learn into the muscle memory that they will incorporate in their day-to-day practice. I'm just thinking from my own clinical work, things get really busy. Unless you're really intentional about deprescribing, it often gets kind of swept under the rug. And how people can build that muscle memory that will allow them just to sort of remember and take the intention to keep doing this as they move forward in their careers.
I'm happy to just share one thought on that, Mike. And again, I'll have Barb and Cheryl bring their comments forward as well. One of the things that's important, I think, it was important in our discussions as well, is deprescribing is really a continuum of good prescribing. So ideally, what we really should be doing is, when they start to prescribe, right away, they need to think about, when do I stop this? What else do I know about risk versus harm? What do I need to know about patients' goals of care? And what is the indication? Am I documenting that? So ideally, if they can do that, Mike, up front, then I think it will become part of the muscle memory. Hopefully, decades down, we won't need the term deprescribing, because it'll become part of good prescribing. When do you start it? When do we stop it? So that's a thought to share, because that's what we're hoping we'll aim towards within clinical practice.
I can comment in terms of some of the literature I presented in the scoping review. I think that's also why, as we critique education, how long does it last? How long does education alone have an impact? So that's just one intervention, one way that impacts our day. There's also other procedures or processes or policies, mechanisms that are in place to help us do our work. So education alone is one factor to give that foundation, but I would argue that we don't actually see from the literature, there's not really evidence that there's that much of a lasting effect. It's more other carrots and sticks in our workplace, pop-ups, reminders, things that affect the processes we have, rather than just the education. At least that's what the evidence says to date. So I think that's something we need to consider going forward as we're creating more research in this area.
Yeah, it's a great question, Mike. There's a really great paper that I enjoy by Gabriella May, looking at clinical mind lines versus guidelines, and talking about how guidelines, for example, don't necessarily make change, but it's the talking about them. It's the water cooler discussion. It's the constant, if you will, bombardment of information, and really just, trying to make this the reevaluation of medications and potentially reducing or stopping them when they're not needed or when there's harm, just making that part of routine care. There's a lot of work on behavior change techniques as well that I think we could apply here. But really, I think we've made a lot of progress, like in the last 10, 15 years that I've been doing work in this area. I've seen just a huge growth around awareness. And so now I think we are at the cusp of, okay, how do we take this awareness and how do we really, really help people learn and do this well?
And Jim, I'm just going to one more point before we get the next question. The other part of it too, I just want to bring to attention is, we're talking about healthcare provider education here, but we can't forget the patients either. This is all about our patients. And so hand in hand goes patient education. And we do know that when patients are aware of what's appropriate medication use and not, they will go to their prescribers and say, should I reassess this? Do I need to come off this? So I would also say, Mike, in addition to how we educate and try to bring that to that muscle power, we also need to support patients in their education. And I know through CADeN, we've looked at that as well, hand in hand, along with the healthcare provider education. So I don't want us to forget about patients initiating this process as well.
Thank you. I'm going to go to Brenda, and then there'll be a question in the chat, please.
I was just going to share, I think that's an important point you brought up about muscle memory. And I was just going to share that in Saskatchewan, as a part of our academic family medicine residency program, we have incorporated into the learning a part of the geriatric skills part of the program, where the resident is responsible to identify a patient and do a thorough medication assessment and potentially identify inappropriate medications and deprescribe. And then as a part of that water cooler talk, I guess, just to pick up on that, they're responsible to, in their second year, sort of identify a patient that they met in first year, and then over the second year, implement a plan and then share back to the academic family medicine group their experience and what went well, what didn't go well. And we have an award at the end of the year just to show our value of these skills for the best deprescribing presentation. And we always say it's not the number of meds that are stopped, but it's the thoroughness and the need for proper evaluation. So the key point I'm making here is incorporating this kind of ongoing learning into residency programs and postgraduate education is important.
Thanks, Brenda. And Barb has put a comment into the chat as well about public education programs with a link for your reference. I'm going to move to a question in the chat from Rohit. How are you incorporating pharmacoepidemiologic data into processes and or reasons for deprescribing, both in academia and in practice? Thank you. I'm not sure who wants to start that one.
I will just start with a broader perspective around that. I'm thinking back to one of the earlier papers we looked at when we started, even before the education piece, looking at evidence-based deprescribing guidelines, Barb. I'm thinking back to that, and Cheryl. We actually needed to know which drugs to target even. And that's where I think those studies became important. You know, what are drugs that are commonly used? What are drugs that are commonly harmful in the older adult? So that actually led us to identifying which guideline should we target in terms of drug-specific guidelines. And so that gave a framework for that. And I have to say that guideline development and implementing the guideline in pilot sites really was, I think, also the impetus around moving it towards education, because we did not want guidelines to sit on the shelf. So we did do pilot studies to see how effective it is in clinical practice. What came out of that also are some of the barriers and facilitators, and some of the barriers being the education piece. So I'll just share that part of it. So pharmacoepidemiology and understanding drug usage in the public domain, adverse effects, common areas where there are problems with it is really important, because that guides us around structuring where the focus may want to be initially, at least around medication appropriate use of medications, I would say.
I think we saw this in some of the literature that we reviewed, that it's more, it varies from jurisdiction to jurisdiction, what are priorities, and based on other policies, we see some settings with very, very low use of some particular groups of medications, and in other settings where policies, coverage, patterns are different, we see high rates of use. And so that's been described as a motivation in some cases for the educational interventions, for other policy interventions, other types of research to look at how to reduce in particular jurisdictions. So that's applied. Many researchers will describe that's how they came to the decision to do a particular study. And then we see that in some of the education where there's examples for how to teach students where to start. And that's just one example, picking a very commonly used medication, or maybe it's expense, or maybe it's a particular age group. And so we see that integrated. There is not necessarily evidence that that's one way is preferable, but more that the education is emphasizing we need to give students a bit of a path on where to start, how to start making those decisions.
Thank you very much. Barb has replaced the questions in the chat and is wondering if anyone in the audience has thoughts about any of them. What are the learnings from incorporating deprescribing within your curricula? What are the challenges to assessment of deprescribing in programs? And how can we determine best practices in teaching and assessment of deprescribing competencies? Does anyone have a comment on any of those three, please?
For example, is there anyone here that is potentially going to the ICOD conference in September in France? And would it be useful to have a discussion session or a pre-conference workshop on education in deprescribing? Just put your answer in the chat or turn your camera on, let us know.
You got a thumbs up from Mike. Okay, I'm not seeing. So we have somebody I hope to be able to come and would love to discuss it. Okay.
And Jim, I just have a question for
Yep.
some of the audience members as well. We have presented the competencies for pre-licensure learners. Any experience anybody wants to share? I know, Brenda, thank you so much. That was really helpful around the postgraduate learners as well and residents. Are there other examples you can share where you're seeing this happen, either with clinicians in terms of continuing education, or with postgraduate learners, your experience and what you're seeing as things that are working well, and there may be some challenges to that as well. We'd really appreciate your insights into that as well.
Comments?
I'll maybe just make a
Yep.
comment if you don't mind. I mean, I only can share what I know, but for those in Canada and other parts of the world, you'd be aware, some would be aware of the fact of educational outreach programs. And I know in Canada, there's been a lot of value around the educational outreach programs, also known as academic detailing, with respect to deprescribing. And so there's been numerous situations, whether it be proton pump inhibitors, antidepressants, medications for insomnia, where there's been educational outreach to clinicians on what's best therapy and when we need to look at deprescribing. And it's been quite successful, I think, as far as utilizing the existing tools that exist here in Canada to make clinicians more aware of them. So I just thought I would share that as far as educational outreach.
Thanks, Brenda.
One thing I'll mention that I've always enjoyed at different conferences I've attended, pharmacy, geriatrics conferences, there's often a stream for education if the meeting is large enough, but there's also sessions such as educators materials swap. And so, for instance, at the American Geriatric Society, so if you attend, you can go to those sessions and bring examples of things you have used in educating your students or trainees, and then share that with others and then get some feedback. And just that dialogue is really helpful. And so I'm, for those involved in ICOD planning, it's something to think about in terms of just, instead of didactic presentations like we might be used to, thinking of more a sharing of materials and swapping materials. And Barb has done a nice job of not even just a swap, just sharing materials. There's so many resources through the web, the links that she has provided as well.
Thanks, Cheryl. I want to be mindful of time. There is one other comment in the chat about foreign graduates coming for licenses in Canada may need information on this topic. With that,
Oh,
we,
I'm just going to comment to Colleen that
Okay.
that's a great point and something, Brenda, we should think about for the knowledge mobilization plan.
thanks, Barb. Okay, we're down to our last 4 minutes. So we're going to launch our final poll to know if this session met met your needs. Nan, I think you're going to launch the poll. There it is. Please fill out the feedback poll, which has appeared. There are 4 questions. And another comment while people are doing that, there are other comments in the chat. Would definitely be useful to have a session at ICAD. Might be interesting to discuss experience on how best to tailor the framework for healthcare providers who have a more restricted scope of practice than in Canada. While people are filling out the poll, just to comment, you may have more questions for our speaker or comments that aren't shareable with a Zoom multiple answer poll. You may also want to be involved with the planning of future Journal Club sessions or want to suggest a future topic. If so, we invite you to write to us at info@CADEN-ReCAD.ca. Thank you again for attending this session, and we hope to see you at our next session. The next session will be hosted by the European Society of Clinical Pharmacy, scheduled from 4 to 5 p.m. London time. The title of the session will be Prescribing Cascades, Recognizing, Preventing, and Managing the Domino Effect. The session description includes that prescribing cascades can be difficult to identify in clinical practice. Even if they are identified, it is not always clear on how to address them. This session provides an overview of key research to help inform the focus and design of guidance, tools, and interventions to minimize the occurrence of prescribing cascades in patients. And the speakers will be Dr. Karen Dalton from Cork and Dr. Lisa McCarthy from University of Toronto. And then we'll put a link in the chat for the sign up for this. I want to say thank you to the organizing committee. This session wouldn't have been possible without the participation of the different groups. And finally, thank you very much. We're very grateful to have had you with us today, and we hope to see you again at a future Journal Club session. Bye for now.
Thank you, everyone.
Thank you. Bye-bye.
Bye.
Bye.